So I think we are done with the lectures. I had a question. Dr. Montserrat very nicely explained all the points. I have noticed that sometimes you will have small particles of, while doing the cataract surgery, there is aqueous misdirection. And you'll also see some, lenticular matter, or even sometimes a very small chunk of nucleus or epinucleus find its way from the zonules and, float around. And then how do you manage that without, disrupting the PC or something? Is there something that you can do?
It's not. Yeah.
As you well explained, in some cases we can show some small fragments in the burger space. And I think this is maybe the first step of if you see that you can have a misdirection. So in these cases, we have to lower the irrigation level in order to reduce the situation. And if the fragments are very, very small, we leave there.
Right. Sure. And any question? Yeah.
The first cases I saw, it was peripheral iridotomy by laser.
What? Sorry?
The first cases you showed, with video for your patient.
Has iridotomy? No.
Laser iridotomy, I think. It's
No.
non-ophthalmos. First cases, I think.
The case in which we have the misdirection, you say?
Before I saw the video, it was done before surgery. I think peripheral iridotomy.
Maybe I don't remember. Maybe yes,
saw
because
it.
yes,
I saw it.
it was
I saw
a
it. I saw it.
hyperopic, yes.
It's a little bit like non-ophthalmos. The question is, in which cases for hyperopia you go direct by anterior approach, and which cases you go by posterior approach? What is your criteria? It's according to anterior chamber depth, according to which criteria, the amount of hyperopia, which in cases you go anteriorly or posterior.
Yeah, in general, we have an anterior approach. In these cases, for example, if we have an ophthalmos, we prefer at the start of the surgery to perform preventive sclerotomies in order to reduce this posterior pressure that can induce the misdirection. Is that the posterior pressure that induce an anterior displacement of these cases. I think in ophthalmos it's useful to have to perform these preventive sclerotomies.
Another comment maybe for teaching for young ophthalmologists to avoid nucleus rotation when we have pseudo-exfoliation without cataract with not enough dilatation, to avoid nucleus rotation.
Yeah.
Maybe, and we saw the first cases which is you do nucleus rotation, that was the complication became.
Yeah, in these cases, the differential diagnosis is that you have the liquid inside the capsular bag. But the problem in these cases, you have to push carefully. If we think that you have the liquid inside the capsular bag, because you can have a posterior capsular rupture. So it's not easy in some cases to differentiate. Because if you have an intraoperative OCT, maybe it would be useful, but in some cases you don't know where is the liquid, but you have to solve that. And maybe the first option, the Hunan balloon, reducing the pressure, can sometimes you can push back the crystalline in order to solve the problem. No?
So I think I had a question for
Gaurav, just my one question to Dr. Amit, that in the in the case of Morgagnian cataract, now the new technique people have been even telling the massaging of the entire capsule just before doing the capsule. This has been, I think, Dr. Nilesh has been put, the paper has been accepted everywhere. Massaging the entire capsule after the I think after putting the trypan blue, then massage the entire capsule, then I don't think so. I think you can go out with the capsule lecture. That's what people say. I think I need Gaurav's opinion and also Amit, whether he has got that experience.
So I think I've been listening to these presentations and I've not tried it myself, but essentially what they're doing is that after you stain the capsule and you put in viscoelastic, then you do a gentle massage of the entire capsule, because you have these clear filled spaces which are just behind the central capsule, and that just tends to shift the fluids and spread it out, so that the moment you puncture it, there won't be a sudden release, and then that sudden decompression which can cause the plaque sign. I think that's what does anybody have experience with that?
So basically lenticular massage, that was a term coined by Dr. Harmesh Lal. So when we do the massage, the anterior compartment, the posterior compartment, basically the fluid is relocated. So the pressure is reduced. But what happens is when you're doing the massage, most of the time these intumescent caraters, the zonals are also weak. So when you're trying to do the massage, sometimes you have a zonal weakness also. So I tried doing that, but I'm not comfortable with that. I feel the needle aspiration gives more guidance and it saves your time, because lenticular massage, you might accidentally excessive massage and the zonals get disrupted.
Right. Also, for Dr. Walid's presentation, you showed some, amazing, videos. I just wanted to ask you, sometimes, you're injecting the lens and most of the lens is inside and the haptic is stuck in the cartridge and you can't, release it. So how do you manage that? Sometimes, the trailing haptic is stuck inside the cartridge.
We manage it with the knife.
You slice the...
Yes, I cut the end of the cartridge, and we avoid to touch the lens because we can damage the lens with the knife. So we have to make another incision to avoid the lens.
So you just have to carefully slice the cartridge,
Yes.
right? Also, you showed that technique which Uday Devgan has shown, where you can, kind of
Twist,
twist the lens. How,
the lens.
how easy or difficult, and how bad is it for the endothelium? I was just wondering.
So that's why we have to put a lot of viscoelastic, dispersive and cohesive. Dispersive to protect the endothelium, and you have to protect the capsule down and the endothelium upper. So, and for this technique, you have to do, you have more ability to do this. And you have to protect the endothelium by the spatula, and we fold the lens forward to the spatula. So with the forces, we push the lens into the spatula to fold it and move it through the incision.
That's why small comments. Walid,
Yes.
in some cases, if the IOL is damaged
Yes.
and you try to remove it,
Yes.
and this is two issue, and endothelium and the capsular posterior.
Yeah.
We can, same case, I do it sometimes with, I teach it for younger, to like scaffold technique, to put the second IOL behind.
Yes.
We are sure that you protect capsular, posterior capsule.
Yes,
And
it's-
the maneuver, it's more easy and less stress.
Yes, I agree with you. Yes, it's a good idea to do this, to protect the capsule.
Just comment for white cataract and Argentine flag. Do you think there is something useful in ocular OCT to quantify how liquid inside the nucleus? Because the lemma, it's gradient of pressure. What is inside the nucleus and is what is outside. And if we can't inverse this gradient, the flag Argentine will happen. I believe we have to quantify before surgery, because we don't take enough time in slit lamp to quantify what is liquid and what is not liquid. What is liquid can go. Just be open. And I think I do some cases by femtocataract, that I stop femtocataract. But I think I discussed with my friend Sami. The unique indication, I think, for femtocataract regarding the cost, it's congenital cataract, hypermature white cataract, and subluxation cataract. And the white hypermature, it's the best indication to do Rexus without a heart attack.
So not everybody is lucky to get a femtocataract with themselves. So if you don't have a femtocataract machine, I think this is the only choice. And what you mentioned is right. An anti-segment OCT preoperatively will always help us to quantify whether it is liquefied or hard. And even if if there's any PCD existing, because a lot of times we get this intumescent cataract combined with the posterior polar component also. So to know the PCD also, the anti-segment OCT will help us.
Yes, I think there's a classification based on anti-segment OCT which is published by Dr. Tityal's group. Yes. So they've actually published the 4 stages of cataract and where it will help. Yes. From AIMS in Delhi, they have published. So if there's any other question from the audience, anything that anybody would like to comment, otherwise we'll finish for the
Photo
day.
for
We'll
everybody.
take a group photo now.